All right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody is doing well today. Today's episode is going to be a little bit different in the sense that it is a throwback, an oldie but a goodie. We're going to bring together a handful of our really important, really critical episodes from the past, primarily covering all things acid, base, and blood gas. This is going to be an absolute masterclass on acid, base, and blood gases. We're going to start with the foundations, go through what acid base is, buffering, pH, PCO2, metabolic, respiratory, all that good stuff, where they're going to dive into the analysis of those blood gases. We'll do a deep dive on anion gap, not just what it is and how to calculate it, but what is the physiology behind it, the causes of anion gap metabolic acidoses and non-anion gap metabolic acidoses. And then we'll get into the delta-delta, the classic delta-delta. Are there overlapping acid-base disturbances? Again, we'll talk about it in a way where we understand the physiology behind it, helping us to really actually grasp what it is. And then at the end, we're going to specifically cover arterial blood gases and venous blood gases, what they are, when to use each, how to convert one to another, what's measured, what's calculated, all that good stuff. You're going to come out on the other end with an incredible understanding of these critical foundational topics. Now, because it is a handful of our throwback episodes put together, you're going to see how we used to do it, which is actually a lot of handwritten graphics and tables and summaries as compared to kind of the typed study guides we do now. So let us know what you think. We actually kind of enjoyed that old production quality, although it certainly took a lot longer. So if you were interested in emergency critical care medicine, this is one for you. Before we dive into it, we just wanted to shout out our Patreon community. If you're looking for an more in-depth emergency critical care education, make sure you check out our Whiteboard Medicine Patreon community. We have quite literally hundreds of additional study guides, practice questions, mini courses, one-pagers, clinical reviews, all the videos ad-free. The community's grown like mad, which we are so excited for because we have been spending and will continue spending tons of time on it. So if you're interested in joining probably one of the largest emerging collections of emergency critical care medical education out there, definitely check that out. Linked in the episode description as well as the pinned comment on YouTube. No further ado though, let's dive into acid, base, and blood gas masterclass.
Disorders. We're going to lay out what acidemia is, what alkalemia is, bicarb and hydrogen ions, how the body buffers the acid-base status, and all those types of things. It's a little bit of a piggyback off of an arterial blood gas video we put out previously. We will link that in this video's description, so definitely check that out too. With no further ado, acid-base disorders and introduction. So why are we talking about this? Well, the body works very, very hard to maintain its acid-base homeostasis. All right, and homeostasis is kind of that regulatory normal. The reason it does this is because, a body that is too acidic or acidemic, the proteins can't function appropriately, the enzymes can't function appropriately. You actually can die from acidemia because at that pH, with all that extra hydrogen ions, your body can't function in its normal manner. The same thing happens when it's alkalotic or alkalemic, all right? And that's kind of too much base. And the body functions a little better with alkalosis to a degree, but once it gets super alkalotic, once there's way too much base, the same thing happens. All those proteins, all those enzymes, the normal medications you take cannot function in environments in the body that are more acidotic or alkalotic than usual. And again, it can lead to death. It also can lead to kind of multi-organ system dysfunction and all those types of things. So how do we define these? So you'll hear us saying both acidosis and acidemia, all right? Those are kind of two different things, right? One has the end emia, that's an M right there. The other one has the end osis, alkalosis, acidosis, all right? These mean slightly different things. So acidemia, EMIA, or alkalemia, means that the blood pH is either acidotic or alkalotic. So for acidemia, the blood pH is less than 7.35, all right, and that's acidemia. Whereas alkalemia, where it's too basic, the pH is greater than 7.45, which shows you that the normal NL normal pH of the body is 7.35 to 7.45. That's the normal. All right. So acidemia, pH of less than 7.35, alkalemia, pH of greater than 7.45. This is slightly different than acidosis or alkalosis, right? Emia versus osis. Acidosis essentially just means that your bicarbonate, which we're going to get into this, but can be a measure of your acid-base status, is less than 24, right? So NL, a normal bicarbonate, is about 24. So if it's less than 24, you're acidotic. But that doesn't necessarily mean you're acidemic, because your body can compensate for its acidosis and maintain a normal pH in the blood. So if your bicarb is less than 24, you are acidotic. You do have too much acid. But whether you're acidemic or not depends on if your body was able to buffer that acidosis and keep the blood pH normal. All right, same thing with alkalosis. Your bicarb is greater than 24, because bicarb, HCO3, this is a base, right? So if it is less than 24, there's not enough base, which means you're acidotic. If it is greater than 24, there's too much base, which means you're alkalotic, or acidosis or alkalosis. And again, just like with acidosis, alkalosis, even if your bicarb is greater than 24, if you have a normal pH, you're not alkalemic because your blood pH is normal, because your body buffered and compensated for that high bicarb to keep the pH normal, to maintain that homeostasis. All right, so does that make sense? Acidemia versus acidosis and alkalemia versus alkalosis. It's somewhat kind of teasing hairs, and these are just kind of definitions, but it is important to get your verbiage right when talking, right? If you're rounding or presenting a patient or thinking about a patient can be acidotic and not acidemic, or they can be both acidotic and acidemic. One, the emia is a matter of the blood pH, and the acidotic or the acidosis is a matter of bicarb. Same with alkalosis, alkalemia. Let us know in the comments if that doesn't make sense. We're happy to explain it further. But those are kind of some of the intro definitions we wanted you to be aware of. So what kind of is acidosis, acidemia, alkalosis, alkalemia? What happens? Well, as many of you may remember from chemistry, hydrogen ions govern the acidity of a solution. All right. The human body is no different, right? So the human body, the hydrogen ions, whether there's too many of them, meaning it's an acidic solution, or too few of them, meaning it's an basic solution, the human body's the same. For those of you who remember chemistry, Henderson-Hasselbalch, there's this equation, the Henderson-Hasselbalch equation from chemistry that kind of teases out blood pH and its kind of proportionality to weak acids or weak bases. We luckily don't need to know that for medicine, so we're not going to dive into that. But the kind of conceptual thing to remember is that hydrogen ions govern the acidity of a solution. Too much hydrogen ions means you're acidic. Too few hydrogen ions means you're basic, right? And alkalosis is basic. Acidosis is acidic. Same thing. Acidemia is acidic. Alkalemia is basic. All right? So this up here is too many hydrogen ions. This down here is too few hydrogen ions. So how does the body go about buffering and trying to keep that blood pH normal, right? Because we talked about the blood pH is what is most important. If the blood pH is normal, even if you're acidotic or alkalotic, your proteins and enzymes and everything are still going to function normal because the pH they're experiencing is normal. Whereas if your blood pH is abnormal, that's when your proteins and enzymes start to struggle. But the body works very, very hard to ensure that even if you're acidotic or alkalotic, that you're not acidemic or alkalemic. And the three main buffering systems are, one, the bones actually. So the bones have a large amount of bicarb, this HC.
If I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients.
CO3, this is bicarbonate, right? And we talked about bicarbonate. Bicarbonate is a base, and it works to buffer the amount of acid, the amount of hydrogen ions, right? It's a base that's negatively charged. Hydrogen ions are positively charged. And we're going to kind of get into how bicarb buffers this. And then bones have a large amount of phosphate as well. So your bones actually regulate the acid-base status of the blood by using its bicarb and phosphate to buffer the amount of hydrogen ions floating around in the blood. In addition to that, there's intracellular buffers. All right, so inside human cells, there's proteins, phosphates, all sorts of ions, right, which are charged particles that can grab onto those hydrogen ions and get rid of them so that your blood pH remains normal. All right, and that's intracellular proteins, phosphates, as we said, all sorts of stuff. So your blood pH. The last and kind of the main one is the bicarbonate carbonic acid buffer system. And this is by far and away the kind of main system, and it's the one we focus on medically. We wrote that down here. This is the one we kind of focus on medically when we're evaluating acid-based derangements, is the bicarbonate carbonic acid buffering system, because this is the vast majority of buffering that goes on uses this system, whereas the other two systems, bones and intracellular buffers, is much more negligible. And what this is this equation here. So it uses a hydrogen ion, right? And this, remember, hydrogen ions govern how acidic our blood gets. And then it uses bicarbonate. And what's happening in your body all over the place constantly is that bicarb and hydrogen are latching onto each other and forming this carbonic acid, H2CO3, right? And this H2CO3 is then broken down into water and CO2 that we can breathe off, carbon dioxide. All right? So this is a constantly happening thing that's happening all over the body. We're going to get into this equation much more in one of the future videos. But this buffering system, essentially, if there's too much hydrogen ions, then the equation... Let's get out a highlighter. So if there's too many hydrogen ions, the equation will go this way, right? And it'll get rid of those hydrogen ions by combining with bicarbonate, going to carbonic acid, then going to water and CO2, and you'll breathe off the CO2 to get rid of it, all right? And that buffers the amount of hydrogen ions. Whereas if there are not enough hydrogen ions, right? So again, too much hydrogen ions, you're going to be acidotic, but then you'll buffer it, and the blood pH will remain normal, so you're not acidemic, okay? Too few hydrogen ions, the equation shifts this way, right? Because there's going to be too much bicarb. These are kind of interacting. So if there's too few hydrogen ions, the equation will go towards the area that has too much, right? And if there's too few hydrogen, there's too much over here, so it goes to the left. And what that then does is it takes water and CO2, breaks it down into, or combines it into carbonic acid, and then breaks it down into hydrogen ions, so that, again, you're buffered so that you don't get alkalemic, right? So too few hydrogen ions means there's not enough acid, there's too much base being bicarb, so you'd be alkalotic, but then this equation, this buffering system in your body says, hey, we need more hydrogen ions, so it breaks down water and CO2 into more hydrogen ions to make sure that blood pH stays normal. So it's this constant back and forth that's going on, you know, this way as well as this way, that creates the right amount of hydrogen ions and bicarbonate using water and carbon dioxide, which are two things that is plentiful in the body and that the body can get rid of, that buffers the blood so that you can try to maintain a normal pH so that you're not acidemic or alkalemic, even if you developed an acidosis or alkalosis. All right? Does that make sense? That is kind of the summary of the introduction, is kind of introducing these buffer systems and starting to understand what drives acidity and alkalinity, the definitions of acidemia, alkalemia versus acidosis and alkalosis, and then kind of the main equation that the body uses to buffer and that we look at medically when evaluating acid-base status. So today we're going to be focusing on primary metabolic and respiratory acid-base disorders. What are they? Why do they happen? How do we determine what is metabolic and what is respiratory? And how can we really kind of conceptualize the physiology as a way to better remember what drives metabolic versus respiratory? To do that, we're going to start with the equation, the buffering system. That is the main buffering system of the body, and that is this equation here. And it's an equation that represents this main buffering system because the body wants to maintain a normal pH always, right? So what they have here is this equation that's going on in the body at all times. And it's hydrogen ions, right, which hydrogen drives the acidity of a solution, bicarbonate ions, which drives the kind of basicness or the alkalinity of a solution. And these two can combine to form carbonic acid, which can break apart into water and CO2. And this reaction can occur in both directions. That's why you have these arrows here. It can go this way, right? Or it can go back this way. Now, when the body has too much hydrogen ions and is going to get acidotic, the equation will shift this way, right? And it'll create the production of more water, more carbon dioxide that will breathe out. And because of that, the pH of the blood will remain normal. Same thing when there's not enough hydrogen ions, right? The equation, so when there's not enough hydrogen ions and you're at risk for alkalemia because it's too basic, the reaction can go this way. And the body will take carbon dioxide and water and form more hydrogen ions to then again maintain that blood pH at normal so that the body is not acidemic or alkalemic. What happens though when this system is just too overwhelmed, when it cannot keep up with the demands of the body, so the buffering system fails? Well, that's where we get into our metabolic and respiratory components, because the kidneys and the lungs affect the amount of different parts of this equation, right? So the kidneys can regulate the amount of hydrogen and bicarbonate, right? It can excrete hydrogen and it can generate bicarbonate. So if this equation is overwhelmed and we have too much hydrogen, well, the kidney can just take this hydrogen and excrete it out, all right? If we need more bicarb, the kidney can absorb bicarb into the blood. And thus, when this equation gets overwhelmed, the kidneys can regulate or compensate for whatever is overwhelming this equation, whether it's acidosis, too much hydrogen ions, or alkalosis, too few hydrogen ions or too much bicarbonate, by how much it's absorbing and getting rid of both bicarbonate and hydrogen. Same thing with the lungs over here with carbon dioxide, right? The lungs breathe in and out, they ventilate. And one thing they do is ventilate out carbon dioxide. So let's say that the body is using this equation to buffer, and there is too much acid, which means that the body shifted the equation this way to try to get rid of the amount of hydrogen ions, which means you're going to have an increase in the amount of carbon dioxide. Well, once this is maxed out where the body's no longer able to shift this towards more carbon dioxide because you already have too much, then the lungs will breathe out the carbon dioxide to get rid of it so that this equation can keep going this way to try to maintain a normal amount of, or a normal blood pH. All right? How does this happen? Well, number one, this reaction is always occurring, all right? It occurs without without an enzyme throughout the body at all times. But in addition to that, there is an enzyme that does catalyze or make this reaction go faster, and that's carbonic anhydrase. And it's in things like red blood cells, the kidneys, renal tubules, the gastric mucosa, the stomach lining, and then pancreatic cells, or cells in the pancreas. So this equation happens, all the things to take away from this little blurb here is that this buffering reaction is going on all over the body at all times, but the body also gets assistance from this carbonic anhydrase enzyme in these different areas to make this equation kind of more efficient, or it catalyzes it to make it happen more. So main buffering system of the body, when the buffering system gets overwhelmed and the pH of the blood starts to get acidemic or alkalemic, remember we talked about that in that first video, whereas the emia means that there's too much, the blood pH is too acidic, so acidemia, blood too acidic, alkalemia, blood too basic. When this buffering system can't keep up and you start to get an acidemia or alkalemia, the kidneys and the lungs say, hey, we will help you out. We will take away or increase certain parts of this equation so that it can buffer again and try to return that pH back to normal. So how does this tease out practically into understanding acid-base disorders from a metabolic and respiratory standpoint? Well, another way to look at this equation, we're going to keep the equation kind of in view here, is that hydrogen ions, and remember, this drives the acidity of a solution. More hydrogen ions equals more acidic, right? So that is proportional to the amount of carbon dioxide in the body, so the pressure in the arteries, the blood vessels of carbon dioxide, divided by the amount of bicarbonate in the body, right? Remember, bicarbonate is a base. So if there's more carbon dioxide, there's going to be more hydrogen ions, and thus you're going to have a more acidic solution. If there's more bicarbonate, so if the denominator of this equation is higher, you're going to have less hydrogen ions, which means the solution is going to be less acidic or more basic. And that comes from this equation, right? So if you take the CO2 and increase it, this equation will shift this way and produce more hydrogen ions, right? Whereas if you take this solution and increase the amount of bicarbonate, it's going to combine with hydrogen, go this way, and there's going to be less hydrogen ions, so it's going to be less acidic. So this kind of proportionality equation is just another way to think about the buffering system equation up here that's going on in the body at all times. And the reason it's good to think about it this way is because it helps us understand metabolic acidosis, alkalosis versus respiratory acidosis, alkalosis, right? And we did put over here, as we mentioned right here, that hydrogen ions drive the acidity of solution. But what are we saying down here? So if you have a decreased amount of bicarbonate, looking at this equation, what do you expect? Do you expect there to be more or less hydrogen ions, aka do you expect it to be more acidic or less acidic? Good for those of you who thought about it. So if this is lower here, the denominator is lower, so H is higher. So you're going to be more acidic. So a low bicarbonate means that there's a metabolic acidosis. Now, why is it metabolic? Well, because the bicarbonate is part of the metabolic processes, whereas the CO2 is part of the respiratory processes, right? You can kind of think of it kidneys versus lungs. The bicarbonate is part of the kidney processes to regulate acid base, whereas the CO2 is part of the lung or respiratory processes to regulate acid base. So a low bicarbonate, which is a base. So another way to think about it is if the amount of base is low, you're going to have more metabolic acidosis. Or you could think of it in this equation. If bicarbonate on the denominator is lower, it means more hydrogen ions, which means more acidic. And bicarbonate is part of the metabolic pathways in the kidney. So low bicarb means metabolic acidosis. The opposite is obviously true here. So if you have a high bicarbonate, so if this denominator here is higher, you're going to have a lower amount of acid, because that's what a proportionality equation means. Denominator higher, H lower, so you're going to have less hydrogen ions. meaning that there's going to be less acidic solution, meaning it's going to be alkalotic, which is basic, and you're going to have a metabolic alkalosis. If this verbiage or terminology is confusing, check out that first video we put out linked in the video description. That's where we go into these definitions. So if the words we're saying are confusing, acidotic, alkalotic, acidemia, acidic, basic, hydrogen, all that, check out that first video. But, so these first two here, we can see that bicarbonate drives whether something is metabolic, and the amount of bicarbonate drives whether it's acidotic or alkalotic based on this equation, which is just another way to think about this equation, right? Bicarb higher, we drive this way, so there's less hydrogen ions and it's more basic. Bicarb lower, we drive this way, so there's more hydrogen ions, all right? And I guess we could write that out rather than just doing quick movements with a pen. So bicarbonate higher means the equation is going to be driven this way, so there's going to be less hydrogen ions, and it's going to be a more basic or alkalotic solution. Whereas bicarbonate lower, the equation is going to drive this way, meaning there's going to be more hydrogen ions and a more acidic or acidotic solution, all right? And again, bicarb is renal. Renal is metabolic, so these are metabolic acidoses and alkaloses. So then what about the CO2 portion of this equation? Well, what we have is if the CO2 is higher, right? So let's go to our equation here. If our CO2, our numerator, is higher, it means that this proportionality, hydrogen's proportional, this hydrogen's going to be higher because the numerator is higher. And that means you're going to have more hydrogen ions, more acidity, and it's going to be an acidotic solution. Because CO2 is the lungs, it's respiratory, so you're going to have a respiratory acidosis. And if we go up to this equation here, we can, understand that based on this buffering equation. CO2 goes higher, drives the equation this way, meaning there's going to be more hydrogen ions. And you're going to have an acidotic solution. All right? Whereas if the CO2 goes lower, here, let's erase these here. So if the CO2 goes lower, the numerator in this equation is lower, meaning the hydrogen, because it's proportional to PCO2 over bicarb, is going to be lower, meaning you're going to have less acid, which means you're going to have a basic solution, and that's going to be a respiratory alkalosis, because alkalosis means basic. And again, respiratory, the lungs up here, are the ones that regulate the amount of CO2. So it's going to be CO2, that's too thick, let's do this here. CO2 is respiratory, bicarb is metabolic, and we can have the higher CO2, top of the equation's higher, acidosis, lower CO2, top of the equation's lower, alkalosis, which we can understand by looking at this equation as well, right? And again, if the CO2 is lower, this equation is going to drive this way, meaning hydrogen ions are going to get lower as the buffering system drives to create more CO2. All right? So if the primary disorder is metabolic, right? Metabolic, we said, is driven by bicarb, which is regulated by the kidneys. So if your bicarb is low or high, and it's a primary metabolic disorder, respiratory system compensates actually within minutes. And we're going to get into metabolic and respiratory compensation in the next video, but this is just to note that the lungs can work really quickly. So if the lungs notice that the kidneys and the metabolic pathways are showing acidosis or alkalosis, the lungs will either breathe off more CO2 or breathe off less CO2 very quickly to try to recalibrate, re-equalize this equation to try to maintain a normal blood pH. Contrarily, though, if the primary disorder is respiratory, meaning the lungs aren't working right, the lungs are either holding on to too much carbon dioxide or getting rid of too much carbon dioxide, the kidneys cannot regulate nearly as fast. Right? The kidneys take hours to days to compensate. So if this equation, this buffering system, if the lungs have a problem and you're, holding on to too much CO2, which is driving the equation this way, producing too much acid, it's going to take the kidneys hours to days before they can kind of auto-regulate and start to excrete more of the hydrogen ions to try to re-equalize this equation. Contrarily, though, if something is going on metabolically and you're getting too much hydrogen ions, so it's causing an acidosis, driving the equation this way, and increasing the amount of CO2, the lungs can compensate very quickly, start to breathe off that CO2, normalize this equation, make it so there's not more hydrogen ions because you're breathing off this CO2, and maintain a normal blood pH. And that can happen very quickly. So it's just something to note when you're kind of in the clinical arena and you're looking at primary disorders that are metabolic. You will often have a close to normal blood pH within minutes because the lungs will compensate very quickly. So even if you're acidotic or alkalotic, you might not be acidemic or alkalemic because your lungs are compensating and kind of returning that blood pH closer to normal. Whereas if the primary disorder is respiratory, you will probably be acidemic or alkalemic for hours to days while the kidneys change kind of how much hydrogen and bicarb they're holding onto and excreting to try to compensate to then return that blood pH back to normal. Today we're going to be diving into kind of the nitty-gritty of acidosis, alkalosis, metabolic, respiratory, compensated, uncompensated, acute versus chronic. It's going to be a video where we dive into a lot of the details, the numbers, the equations, while we keep kind of the general physiology in mind. So stick around while we go through all this. So to start, you would get an ABG, all right? The ABG gives us a view into the acid-base status of a person. So when you're evaluating for an acid-base disorder, you get an arterial blood gas. We actually did a video on arterial blood gases, again linked in the video description, and that arterial blood gas is a poke into the artery, and it gives us a glimpse into the acid-base status of a person, if you're worried that they're acidemic or alkalemic. In addition to that, the ABG, as we talked about in that other video, so it'll give us the pH like we mentioned. It'll also give us two other things we need though, and that is the PaCO2, which is the partial pressure of carbon dioxide in the arteries, and it'll give us the bicarb, all right, the bicarbonate. The bicarbonate is a calculated value, whereas the CO2 is a measured value, but they all can still be used. You could also get the bicarbonate off of a basic metabolic panel, which is a venous blood test. But when you want to know about acid-base disorders in a person, send that arterial blood gas. Depending on the results of that arterial blood gas, we can kind of walk through an algorithm. And if that arterial blood gas shows, a pH of less than 7.4 or less than 7.35 would be another number, or if it's greater than 7.4 or greater than 7.45, because the normal pH is generally considered 7.35 to 7.45. All right, so if the pH is less than that, 7.35, it is acidemic, an acidemia, and we talked about acidemia versus acidosis in that first video. If the pH is greater than 7.45, it's alkalemia. Acidemia is that the blood is too acidic. Alkalemia is the blood is too basic or alkalotic. How do you determine, though, if it's a metabolic versus a respiratory acidemia or alkalemia as the primary disorder? Well, there's a few ways you can look for that. If we start with acidemia, so we get our arterial blood gas and that pH is less than 7.4 or less than 7.35, so we know there's an acidemia. The next thing we're going to look at is the bicarb or the PaCO2. So we're going to look at the bicarbonate level or the PaCO2 level, the carbon dioxide level on that blood gas. If that bicarbonate is less than 24 milliequivalents, then you know that acidemia is a metabolic acidosis. In the previous videos, we've talked about why that might be, and it comes to this equation that we spent a lot of time on in those other videos, which is hydrogen and bicarb, which can go to H2CO3 carbonic acid, which can go to H2O, those are supposed to be two arrows, H2O plus CO2. So if our pH is less than 7.40 and our bicarbonate is low, bicarbonate is a base. So if the base is low, it's acidotic. So if that bicarbonate is low, you know that it's a metabolic acidosis. All right, and we're going to get into this next level about like kind of the compensatory stuff in a second, but we're going to stick above that green line for now. Whereas if instead the PaCO2 is greater than 40, that would be a respiratory acidosis. So anytime you have a pH less than 7.40, then look at your bicarbonate and your CO2 levels. If that bicarbonate is low, you know it's a metabolic acidosis. Whereas if that PCO2 is high, you know it's a respiratory acidosis, right? Because if this is increased in this portion of the equation, it shifts the equation this way and leads to an acidemia because it will produce more hydrogen ions. Whereas if the bicarbonate is low, you're going to have more hydrogen ions in that equation as well. So that is how you determine whether it's a primary. So this is going to be the primary disorder. That's a weird P, primary disorder in this tier. And that's how you determine if it's a primary metabolic acidosis versus respiratory acidosis. It depends on the bicarbonate level and the CO2 level. Now, if you get your arterial blood gas and that pH is greater than 7.45, that's an alkalemia. This means that blood is too basic. And again, we'd go to our bicarbonate and our PaCO2 level. So opposite the acidemia, if our bicarbonate level is greater than 24, that's going to be a metabolic alkalosis, right? Because bicarbonate is a base. So if it is high, it means that the alkalosis is because of the bicarbonate, and that is a metabolic alkalosis as the primary disorder. If that PaCO2, though, is less than 40, that's going to be a respiratory alkalosis as the primary disorder. Now keep in mind you can have mixed. So if the bicarbonate is greater than 24 and the PaCO2 is less than 40, it would be a mixed metabolic plus respiratory alkalosis. That'd be the same thing over here. If the bicarb is less than 24 and the PaCO2 is greater than 40, it would be a mixed metabolic and a respiratory acidosis. All right, and that's how you can follow this chart to kind of determine the primary disorder. And again, if we go back to our equation over here, if that PaCO2 is less than 40, so if the PaCO2 is low, it means that the equation is going to go this way, so it's going to decrease the amount of hydrogen ions, and thus you're going to have less hydrogen ions and a more basic solution, or more alkalotic solution. And again, if that's confusing to you, that's what we've talked about in those first two videos, so definitely check those out. So now that we've talked about the primary, we wrote primary out over here. Here we'll do one with a degree sign, which stands for primary. So now that we know whether the primary disorder is acidemic, alkalemic, metabolic versus respiratory, then the question is, well, is there compensation? So there's two things that can compensate for an acidemia or alkalemia, and that is either respiratory or renal. Renal is metabolic. All right. And we cover this in the other videos why that is. So the kidneys, right, if we draw a little bean here, the kidneys can either absorb more bicarbonate or excrete more hydrogen ions, and that's how they compensate renally for an acidosis or alkalosis. Whereas the lungs, right, the lungs can breathe out CO2 or hold on to CO2, and that's how the lungs, the respiratory, compensates for an acidosis or alkalosis. So if we go down this route and we have an acidemia, or pH is less than 7.4 or 7.35, if the bicarb is less than 24, meaning it's a metabolic acidosis, then you look to the carbon dioxide. And if the carbon dioxide is less than 40, meaning, if we scroll up to this equation, meaning the carbon dioxide is low, so it is shifting the equation this way and decreasing the number of hydrogen ions, trying to make the blood have less hydrogen ions or be less acidotic, then the respiratory system is compensating. So if the PCO2, if the carbon dioxide level is low in a metabolic acidosis, that means that the lungs are compensating. And we're going to get into some specific numbers and equations in a second. Contrarily, if it's a respiratory acidosis, so our pH is less than 7.4, our PCO2 is greater than 40, so it's respiratory, meaning that CO2 is high, and the CO2 is driving the equation this way, meaning there's more hydrogen ions, and thus the solution is more acidemic. Then we look to the bicarb to see if there's a renal or metabolic compensation. If the bicarb is high, trying to increase the amount of base to balance out the respiratory acid, then you know that you've renally compensated, or the kidneys are trying to compensate. Now keep in mind the lungs, the respiratory compensation happens much faster than the kidneys or the metabolic compensation. So a respiratory compensation can happen in a matter of, minutes, whereas a renal or metabolic compensation takes more like hours to days before it can compensate. All right? Approach is similar for alkalemia. So if we have a metabolic alkalosis, pH is greater than 7.4, our bicarb is high. A bicarb is a base. Base is alkalotic. So if our bicarb, our base is high, that means it's a metabolic alkalosis. Then you look to the CO2. And remember, a high CO2 drives this equation to make more hydrogen ions, which means that it's trying to make the blood more acidic. So if the CO2 is high, it means it's trying to balance out this alkalosis, right, by increasing the amount of hydrogen ions. And that means that there's been a respiratory compensation. Contrarily, if it's a respiratory alkalosis, so our pH is greater than 7.40, our pCO2 is low, meaning there's less hydrogen ions, meaning it's alkalotic or basic from the respiratory system because the lungs control the CO2 concentrations. Then you look to the bicarb. If the bicarb is low, bicarb's a base, so low bicarb means there's less base, meaning it's a more acidic solution. Then there's a metabolic compensation happening. Okay, we're going to pause here and just give you a second to kind of digest that. So some of this stuff might be straightforward, right? pH less than 7.4, alkalemic greater than 7.4, acidemic greater than 7.4, alkalemic. In an acidosis, bicarb less than 24 means it's metabolic because bicarb's a base. Base is alkalotic, so less base means more acid. If the carbon dioxide is greater than 40, you know that higher carbon dioxides drive the equation this way, producing more hydrogen ions and more acid. That means it's a respiratory acidosis. And that's kind of flip-flop whether it compensates, right? Because to compensate means you're trying to bring the blood pH back to a normal amount. So if the primary disorder is an acidosis, the appropriate compensation is trying to make the blood less acidic, or almost you could think of it like trying to induce an alkalosis to balance it out. So if we know that high CO2 is acidotic, low CO2 is alkalotic. So if there's a metabolic acidosis, having a lower CO2 means that those lungs are trying to make the blood more alkalotic, more basic, less acidotic. So there's an appropriate respiratory compensation. All right. Same thing, over here. If there's a metabolic alkalosis, meaning the blood is not acidic enough, the appropriate compensation is try to make the blood more acidic. So the respiratory system should be increasing the amount of CO2 because that will drive this equation to make more hydrogen ions, which makes the blood more acidic, and that's an appropriate respiratory compensation. This is in contrary to if the opposite was happening, where then you'd have a combined metabolic and respiratory acidosis or alkalosis. All right. So how do we know if it is the compensatory mechanism is happening appropriately, right? Because what should your CO2 be when you're compensating? Well, it depends on what your pH is and what your bicarbonate level is. And there's actually equations put forth to calculate this. Unfortunately, these are equations that would just need to be memorized. They're very common equations that come up on the wards. The first is Winter's formula. So Winter's formula is a equation you would use if there's a primary metabolic acidosis. Remember, that means the pH is less than 7.35, okay? And the bicarb, which is a base, which is alkalotic, is less than 24, meaning there's more acid. And this is a metabolic acidosis. What should happen in a metabolic acidosis is a respiratory compensation, meaning the respiratory system should be trying to make the blood less acidic or more basic. And to do that, right, you would need a decrease in your carbon dioxide level, a decrease in your PaCO2. But how much should that PaCO2 be decreased? Well, that is what this equation tells you. So the expected PaCO2, meaning if there were appropriate compensation from the lungs to compensate for the metabolic acidosis, this equation would derive what the CO2 should be. And that is 1.5 times the bicarbonate level plus 8, plus or minus 2 is just kind of a degree of error. So what that would look like is, here's an example. So your bicarbonate level is 14, your pH is 7.31, right? So this is less than 7.35, so it's acidemic. Your bicarb is less than 24, meaning it's a metabolic acidosis. So what should your lungs be doing for an appropriate respiratory compensation? Well, 1.5 times the bicarbonate level, right, which is 14, plus 8 plus or minus 2. So the PCO2, the carbon dioxide level in the blood off that ABG, should be somewhere between 27 and 31 if the lungs are doing the right thing to compensate. And as we said, a decreased PCO2, right, which is less than 40, would be a respiratory compensation. And if that PCO2 comes back on the arterial blood gases between 27 and 31, then what you have is a metabolic acidosis with appropriate respiratory compensation. All right? This results in about a decrease of 1.2 millimeters of mercury in the carbon dioxide level for every decrease of 1 in the bicarbonate level. So that's kind of a little kind of cheat if you didn't want to do the whole equation. So if you just the PCO2, the CO2 level should decrease by about 1.2 for every decrease of 1 in the bicarbonate level. So it'll give us a little different answer, but if we use that, normal bicarb, as we talked about, is 24. The bicarb in this equation was 14. So that means there's a decrease in what? A decrease in 10 milliequivalents of bicarb compared to normal. And what this cheat is saying is that the CO2 should decrease by 1.2 for every 1. So if we times this by 1.2, let's see if I could do math here quick. That's going to be what, 12-ish? About 12. So there should be a decrease in about 12 millimeters of mercury of CO2 if the lungs were to compensate appropriately. A normal CO2, NL normal CO2 is 40. So that minus 12 would give us what? 28, which gives us about what the equation gives us as well. So if you don't want to do the equation, you just want to memorize 1.2 for every 1, you could do that as well. So that's Winter's formula. That is strictly for a metabolic acidosis. Oh, you can't see that. We're going to erase that. All right. What about, though, if the primary disorder, instead of being a metabolic acidosis, is a metabolic alkalosis? So this is the primary one with a degree. That's primary disorder. This is the primary disorder. All right. Well, there's another equation to calculate whether the CO2 compensates for a metabolic alkalosis. Right. So metabolic alkalosis, pH of greater than 7.4, or you could say 7.45. That's a little sloppy. We're going to write that again. 7.45. And a bicarb level that's going to be high, right? Because metabolic alkalosis, bicarb is a base. So if you have a high bicarb, you have a metabolic alkalosis as your primary disorder. This is still super sloppy. All right, third time's a charm here. There we go. So if the primary disorder is a metabolic alkalosis, then what you would be looking for is, do you have appropriate respiratory compensation, right? And we know that high CO2s, so to compensate, you would expect the CO2 level to be trying to induce more acidosis, right? Because the primary disorder is alkalosis. So to compensate and try to bring that pH back to normal, you need to have the lungs be inducing an acidosis, because acidosis and alkalosis balance each other out to net neutral. And as we talked about, high CO2 increases the amount of hydrogen ions, which increases the acidity of the solution. So you expect the lungs to be holding on to CO2 and increasing the CO2 level. But how do we know that the lungs are doing a good enough job? And that is what this equation shows. So this is the expected PCO2, right? The carbon dioxide level that would be expected if the lungs were doing their job to compensate for the metabolic alkalosis. And the equation is going to be 40 plus 0.6 times the bicarb. All right? So if we just do, let's see, we can just make up a problem right now. So the pH is going to be 7.50. 7.50. The bicarb is going to be high, right? Because it's a metabolic alkalosis. 24 is normal, so we're going to say the bicarb is 32. So if we do this equation, 40, wow, we don't know why there's that lag with our writing, apologies, plus 0.6 times the bicarb, which is 32. And to be fair, this is not appropriately compensated because the pH is not about normal. So we're going to change the pH to show that it's compensated. So the pH is 7.45 with the high bicarb. 0.6 times 32. We've got our handy dandy phones here and get our calculator. Could have done this ahead of time, but we decided to do a problem on the spot. So 0.6 times 32 plus 40, you would expect the PCO2, the carbon dioxide level, to be 59 if the lungs were appropriately compensating. Remember, normal carbon dioxide is 40. So this is high. As we said, it should be high to compensate for metabolic alkalosis. All right, and then some throughout this cheat kind of shortcut way, we're just going to cross that out. It gives you a little bit different math. So when it comes to respiratory formulations, right, so these were primary metabolic. But if the primary disorder is respiratory, there's actually a nice little cheat box way in which you can remember the compensation, and that is this here. But we want to explain what it's laying out because it can be a little confusing. So for this, it's important to know whether it's acute versus chronic respiratory, right? This comes into play for respiratory, primary respiratory, because if you have something like COPD, right, chronic obstructive pulmonary disease, or emphysema is another kind of way to think about it, you are a chronic retainer of CO2. So if you are a chronic retainer of CO2, your CO2 levels are always a little bit high, and your kidneys compensate a little differently for those constantly high CO2 levels. There's other diseases that cause this too. It's not just COPD and emphysema, but if you are a chronic retainer, then this is going to be different. This would also be for someone who, they might not be a chronic retainer, but they have a pathology that has been going on for a number of days or weeks that changes them to have kind of a different baseline level of CO2, a more chronic, rather than like an acute that just happened over hours, change in their CO2 levels. So when we look at this, the left column is for a primary disorder of respiratory acidosis. The right column is for a primary disorder of respiratory alkalosis. Not sure if this is helpful for anyone else, but the way we remember this is that the first letter that differs between respiratory acidosis and alkalosis is this second letter. And C comes before L, thus C and acidosis is in the first column, and L and alkalosis is in the second column. Not sure if that's helpful for anyone else. Our brain's weird. Then what you have in the first column is the carbon dioxide level, which is C. And in the second column, you have the bicarb level, which is H. It's a little cheating because we're ignoring the P. Let's actually just erase the P. We don't even need it. So again, CO2 is in the first level, comes earlier in the alphabet. H is in the second column, comes earlier in the alphabet. I think we said level. So CO2, respiratory acidosis, first column, respiratory alkalosis, bicarb, second column. And then you have acute, first row. Acute comes first, chronic, second row. Chronic comes later. And what this is telling you is the change in the CO2, because CO2, right, is first, semicolon, compared to the change in the bicarb that you would expect for a compensated respiratory acidosis. So what does this actually look like? What they're saying is that for a respiratory acidosis, so you have a respiratory acidosis that's compensated, so we're going to say the pH is 7.32, slightly low. It's respiratory, right? Respiratory acidosis, the PCO2 is high because high carbon dioxide drives that equation to the left, produces more hydrogen ions, so the PCO2 is high, greater than 40, so it's going to be 49. For every increase of 10 in the carbon dioxide, which means we're going to make this an even 50 for the ease, there's going to be an increase of 1 in the bicarb to compensate. So if you've increased your carbon dioxide to 10, that means your bicarb, a normal is 24, you're going to expect your bicarb to be 25 to compensate. All right. Similarly, that's acute, right? So if it's acute respiratory acidosis, where if you have a chronic respiratory acidosis, let's do the same thing. We're going to put a little A here because this is the bicarb that would be there for acute. If you have a chronic respiratory acidosis, for every increase of 10 in the carbon dioxide level, increase of 10 in the carbon dioxide level, semicolon bicarb, you'd have a semicolon increase of 3 in the bicarb. So you'd expect the bicarb to be 27 from 24 for a chronic respiratory acidosis with metabolic compensation. All right? So this is, increase in carbon dioxide level compared to increase in bicarb level. First column, respiratory acidosis. Second column, alkalosis. This is the same verbiage, but instead of increase, it's decrease. So for respiratory alkalosis that's compensated, we'll say for alkalosis, pH is, but it's going to be compensated, so it'll be let's say it's 7.44. So between 3.5 and 4.5, but a little higher than 4. It's a respiratory alkalosis, so our PCO2 is going to be low, right? Because low PCO2 shifts the equation to the right, consumes hydrogen ions, so there's less hydrogen and more acidosis. So our PCO2 is going to be low, less than 40. We'll say the PCO2 is 30 for the sake of ease of math. So for an acute respiratory alkalosis, the metabolic compensation, you would expect the bicarb for every 10 decrease in the CO2, the bicarb to decrease by 2. Normal bicarb is 24. So you expect the bicarb in a metabolically compensated acute respiratory alkalosis to be 22. Whereas if it was a chronic respiratory alkalosis, for every 10 decrease in the CO2, right, you'd expect a decrease of 4 in the bicarb instead of a decrease of 2 in the bicarb. So instead of 22, normal bicarb is 24, you'd expect the bicarb to be 20 for a chronic respiratory alkalosis with metabolic compensation. Does that make sense? Hopefully it does. The chart, once you get to know it, makes a lot of sense. And it's actually kind of nice, right? Because what it actually ends up looking like is over here. You have 1, 3, 2, 4, which is somewhat easy to remember because the constant here is the change in the PCO2. It's always either an increase in 10 for acidosis, which we know CO2 increases in acidosis, or a decrease in 10 for alkalosis. And then what we lost our microphone there for a second. And then what the bicarb does is either increases by 1, increases by 3, or decreases by 2, decreases by 4. So what you have is something easier to remember. You have 1, 3, 2, 4. Or 1, 2, 3, 4, whichever way you want to remember it, as long as you remember the parts of the chart, which this is respiratory acidosis versus respiratory alkalosis. We remember it because C comes before L in the alphabet. And then acute versus chronic. We remember it because acute is before chronic. And that's 1, 2, 3, 4, or 1, 3, 2, 4, whichever way you want to memorize it. Today, everything you need to know about anion gaps. So the first principle here is that plasma, or blood plasma, is always net neutral. Just about net neutral, meaning that the positively charged particles balance out the negatively charged particles. There's the same amount of each of them. And these positively charged particles we refer to as cations, and the negatively charged particles we refer to as anions. And the concentration, in brackets, concentration of these is about the same, to the point where they cancel each other out, and we end up with a net neutral substance. And that substance is our plasma or our blood. Well, this can be helpful when we talk about acid-base disorders, particularly when we're talking about metabolic acidosis. All right? Anytime you have a metabolic acidosis, you want to know, is this an anion gap metabolic acidosis, an AGMA, or a non-anion anion gap metabolic acidosis, or a NAGMA. All right, because this will hone in on the differential diagnosis for the cause of that acidosis. What is causing it will be related to whether it produces an anion gap, such as an AGMA, or a non-anion gap. All right, it's not helpful for metabolic alkalosis. It's not helpful for respiratory acidosis or alkalosis. It's really just helpful for metabolic acidosis. So when we look at the anion gap, what we're actually talking about is a lab calculation. All right, the anion gap is often reported on a basic metabolic panel, a BMP, but that's just the lab calculating it. It's not a direct measurement. And what that calculation is it's a look at what are the primary measured cations and anions in the body. And we have them written out here. Right, so the anion gap's the difference between, well, we'll get into this, is the difference between the unmeasured cations and anions. But to understand that, we have to know what the normal measured cations and anions are. So the measured cations and anions are primarily sodium, Na, sodium, and potassium, which are cations. They're positively charged. And sodium is above and away the biggest contributor. The two measured anions are bicarbonate, HCO3 bicarbonate, negatively charged, and chloride, negatively charged. So when an anion gap is calculated, you are essentially looking at the difference between these two main measured cations and these two main measured anions. And the difference between them is going to be the difference in the unmeasured cations and unmeasured anions. Does that make sense? Right? Because we know that plasma is always net neutral, and we know that there's a lot of unmeasured cations and unmeasured anions. Things like phosphate, things like sulfate, things like calcium, right? So phosphate's negative, negative, calcium's positive. Even negative and positively charged proteins like albumin that's negatively charged. All these are unmeasured, right? And you can measure them in, fancy science experiments, but we don't measure them kind of traditionally, daily in the hospital, with some exceptions, calcium, phosphate, all those kinds of things, albumin we sometimes do. But nonetheless, the anion gap is just a calculation. The lab isn't doing some fancy thing looking at all these unmeasured ones. The lab is literally taking the sodium and potassium and then subtracting the bicarbonate and chloride. We'll get into this a little bit more because they don't always look at the potassium. So to understand this, I think we need to go down to the equation and then we'll circle back up. So the equation for an anion gap, an AG and anion gap, and this is what the lab's doing, is sodium, right, cation positively charged, plus potassium, cation positively charged, both on your basic metabolic panel, your BMP, minus the chloride, negatively charged, plus the bicarbonate, negatively charged. All right. The normal value is 12 to 16. So what that is saying is that this equation leaves, 12 to 16 positively charged particles greater, positively charged cations greater than, the negative anions, right? But plasma's net neutral. So what it's essentially saying is something is going on at the body where this equation is always going to leave more positive than negative. Quick before we dive into the details of that to further tease it out. Most places kind of ignore the potassium because potassium only contributes very little, right? There's all this sodium and then there's a small amount of potassium. So the equation most labs use is this one, which is just sodium minus chloride plus bicarb, and the normal is 8 to 12. All right, so let's scoot over now and kind of tease out what that means. Well, we know that there are a number of these unmeasured cations and unmeasured anions, and the anion gap is just looking at the difference between, right, sodium, positively charged, and then bicarbonate, negatively charged, and chloride, negatively charged. And the normal is 8 to 12. So if you just look at these, you always will have 8 to 12 cationic particles more than the anions. And this is normal, right? Because what the equation isn't taking into account, right, is all these unmeasured cations and unmeasured anions. This isn't to say that the blood is always positive 8 to 12. It just is saying that when you only look at these three, you are missing a number of negatively charged anions that would neutralize this and cancel this out. So this is a non-anion gap. This is normal. All right, because you have all these unmeasured anions. A big one is actually albumin, a protein that floats around. We all have a bunch of albumin that's very negatively charged, right? But there's all these other negatively charged particles that are canceling out the positive cations that this equation implies are always floating around to make sure that you stay net neutral. All right. So what we do when we look at anion gap is not anion gap is we're essentially using this imperfect equation to tell us something about the state of the cations and anions. How does this relate to acid base? Well, these we talked about in the beginning videos, right? You have hydrogen ions, which are positive, and these are acidic, and you have bicarbonate ions, which are negatively charged, and these are basic, right? But for the sake of this equation, it's easier to think about kind of the positive acidic molecules. So acids are cations, are positively charged. So if we have a high anion gap, it is implying that there has been a change in the amount of acidic compounds in the blood because acids are positive. So if we increase the amount of positive particles, meaning there's more acid around, and you leave the amount of negative particles, what's going to happen in the body is that you're going to have bicarbonate, right, a base come in here, neutralize these acid particles, so you're going to have less bicarbonate. If you have less bicarbonate, this equation, sodium minus chloride, right, plus bicarbonate, your bicarbonate has gone down, so this is going to equal a higher anion gap. And that tells you something, whereas the body compensates for these changes to keep the blood net neutral. Things to keep in mind, and again, we're going to tease that out more below, but when we're doing this equation, things to keep in mind, we got a little ahead of ourselves, is that you have to take albumin into account when doing the anion gap equation. It's one of the few things that you really need to take into account to give you an accurate number, because if you have a low albumin, as we talked about, albumin, ALB, is very negatively charged. Right? It's covered in negative charged anions. So if we don't take albumin into account, you will have a falsely low anion gap. Because the equations, when they did the experiments to look at what was normal, they looked at it in patients who had a normal albumin. So again, if we're doing the anion gap calculations, and it's positive minus negative, and the normal is assumed to have a normal albumin, but your albumin is low, meaning you have a big decrease in the number of anions, right, the number of negative particles, then what you're going to actually see is that there is something going on, but you're just missing it because you didn't take into account albumin. If we think about that kind of in drawing form, if a normal anion gap assumes the albumin concentration is normal, and you have a normal anion gap but a low albumin, what's actually going on is something has taken the place of albumin, right? So let's say we have a normal anion gap, 4 positives, we'll say kind of 3 negatives, just for the sake of this drawing, to make a normal anion gap of about 8 to 12. But that is with all this albumin that's negative floating around, right? Well, if it's 8 to 12, but you have low albumin, so you only have 1 albumin floating around, what that is telling you is that you have another molecule present that is compensating for that low albumin, right? So essentially, there's something else here that is compensating for that albumin not being around, that is making the anion gap look normal, even though it is not. So you always have to correct for low albumin. The correction equation is this: sodium minus chloride minus bicarb plus 2.5 times 4 minus albumin. 4 is the normal albumin concentration. So it's essentially the anion gap equation, but then you just put a little addendum here: 2.5 times 4 minus the albumin. So if the albumin is 2, normal albumin is 4. 2.5 times 2, or times 4 minus 2, which equals 2 times 2.5, which is 5 total. You'd add that onto the anion gap. So if we got an anion gap of, let's say, 11, and we were saying, oh, the anion gap's normal, well, you got to correct for albumin. If you have hypoalbuminemia, 11 plus 5 is 16. And this is actually an anion gap, meaning that there is something going on in the blood that we're going to talk more about, creating a higher anion gap than would be measured otherwise. So always take into account hypoalbuminemia. Let's get into what exactly could be going on and how high versus normal anion gap helps us. Well, a high anion gap, or sometimes we just call it an anion gap, metabolic acidosis, means that there are unmeasured acids floating around in the blood. We're going to get into this, but first we want to say, so we can kind of clump both, a normal anion gap means that you're just losing bicarbonate, not loosing, too many O's, losing bicarbonate. But you don't have any extra acidic compounds floating around, you're just losing bicarbonate. So what exactly does this mean? Well, two things. One, acids, as we talked about, not to be an old drum, are positively charged, right? Hydrogen ions are acids. So something like lactate, lactic acid. Patients in septic shock sometimes develop a lactic acid anion gap metabolic acidosis. Well, lactate is a molecule, and this isn't its actual structure, right? But it has all these OH, all these kind of hydrogen ion groups going on, all right, to think about it that way. So do keto acids, someone in diabetic ketoacidosis. So what you can think of it as is these acidic compounds are giving the body all this extra hydrogen ions. So what has to happen for the body to try to compensate? Well, you're going to have all this bicarbonate coming over here to try to neutralize that acid. So what's going to happen is you're going to get a decrease in bicarbonate. So then when you do your equation for anion gap equals sodium hasn't changed, minus chloride hasn't changed, plus the bicarbonate. Well, the bicarbonate is much lower now because all this bicarbonate has tried to neutralize this new acid floating around, and thus the anion gap is going to be high because the equation being used has less bicarbonate present. This is in contrast to, actually we'll just leave this up and we'll scroll to the right. This is in contrast to a non-anion gap. So you have, in an anion gap, you have extra acid, and this will be helpful to think about when we talk about kind of the differential diagnosis of anion gaps. So you have extra acid, right? And this is an anion gap metabolic acidosis, an AGMA. A non-anion gap, ooh, that's very lagged, apologies. A non-anion gap metabolic acidosis, or a NAGMA, does not have extra acid. You're just losing bicarbonate, which is a base. All right. Something that happens, though, when you lose bicarbonate is you actually increase your chloride. Your body does this while you're losing your bicarbonate. And what happens here is, if we look at the equation for anion gap, right? Anion gap equals sodium, unchanged, minus chloride plus bicarb. So your bicarb you're losing with a non-anion gap, but when you just straight lose bicarb, it's not that the bicarb is trying to neutralize acids, you're just losing it. And we'll get into some of the ways you can lose it. Your chloride auto-regulates and increases, which makes this anion gap normal, because the amount of chloride increased is equal to the amount of bicarb lost. So do you kind of see the two different pathophysiologies that are going on here? In an anion gap, you have the production of an extra acid, lactate, keto acid, formic acid. We'll go through these things. Whereas in a non-anion gap, there's no extra acid being produced. You're just losing bicarb for a reason. And if you just lose bicarb, your chloride automatically increases to make this kind of a net neutral, bicarb down, chloride up, which makes the anion gap stay normal. All right. So what does this mean? How does it help? Well, it helps us in terms of deciding what is causing the metabolic acidosis. So we got these from this Understanding Acid-Base Disorders. It'll be linked in the video description. Definitely check it out. So a high anion gap metabolic acidosis, or a HAGMA, this is sometimes just called actually an AGMA. It's not necessarily a HAGMA. AGMA just stands for anion gap metabolic acidosis. Apologies, we don't know why this is lagging so much. These, right, we talked about, are from the production of an extra acid, right? Because as we said, the extra acid consumes bicarbonate so that there's less bicarbonate in that equation, right? Sodium, as we talked about, we're just going to do repetition here. Sodium, anion gap equals sodium minus chloride plus bicarb. So the acid being the new acid, the extra acid, consumes bicarb, and then this leads to a higher anion gap. So they all have unmeasured acids. These are some mnemonics people use: Goldmark, Carmel, Mudpiles, Kurzweil. But the similar thing here to remember is all of them have extra unmeasured acids being produced, right? So G is glycols, O is oxaloproline, lactate, methanol, which goes to formic acid, salicylates or aspirin, renal failure, keto acids, etc., etc. And this is kind of just all similar things, but they all produced unmeasured acids. And those unmeasured acids consume bicarb, which makes your anion gap that you're calculating, because it's a calculation, it's not directly measured, it's a calculation, it makes your anion gap higher. All right? Whereas a non-anion gap, a NAGMA, as we talked about, so this is non-anion gap, you're just losing bicarb. You're not creating an extra acid. This is like GI losses of bicarbonate. You know, if you have a lot of GI losses. Renal tubular acidosis, this is where you just don't absorb bicarb. All right. Treatment with a carbonic anhydrase, which excretes bicarb. Excessive administration of normal saline, this one actually just increases your chlorine, because normal saline is NaCl. So you see the difference here? The non-anion gap ones, you're not having this extra acid being produced. You're just losing bicarbonate. And what we talked about, right? Again, repetition, anion gap equals sodium minus chloride plus bicarb. And if you just lose bicarb, your body automatically holds on to more chloride. So this is net neutral, and it ends up with a normal anion gap, because these cancel out. Hopefully that makes sense. We know that there's a lot here between kind of pathophysiology and then understanding how to apply the anion gap and non-anion gap, but hopefully that makes sense. This is something that we use almost daily in the ICU. It's in the emergency department, on the general floors. Something that's really important to get a good grasp on. And in our mind, it's easiest to get a good grasp on it if you kind of understand the physiology behind it. Understand that it's just an equation being used, and that equation is imperfect, and we kind of use its imperfections to our advantage, right? If there's more bicarbonate being consumed, so the anion gap is higher, that tells us something. Whereas if it's just bicarbonate being lost, then the chloride automatically increases, so the anion gap's still normal, that tells us something as well. Yeah. All right. Delta gap, delta ratio. So this comes in handy if you have a metabolic acidosis with an anion gap. So as we talked about in the last video, if you have a metabolic acidosis, the next thing you want to do is calculate if there is an anion gap. If there is an anion gap, then what you want to do is this, the delta gap or the delta ratio. We'll just put delta. The verbiage here can get confusing. People say delta gap, people say the delta, people say the delta ratio. All of those are looking at the same thing, but they just look at it using slightly different equations. All right, but delta gap, delta ratio, all that is getting to the same kind of working to get to the same conclusion, but just doing it in different ways. And we'll go over some of that. So what this delta gap does is it determines if there could be a combined acid-base disorder. So essentially it can determine if there is a combined non-anion gap metabolic acidosis with a high anion gap metabolic acidosis, or even if there's a metabolic acidosis with a metabolic alkalosis. And this is really important when you're thinking about what is causing the acid-base disorder in a patient. You need to know if there's some of these combined disorders. This is some advanced acid-base stuff. This would be very impressive, to do on the wards and things like that. And it also is something that is commonly tested on. So the equation for the delta gap, the first way we're going to look at this, is the delta gap equals the delta anion gap minus the delta bicarbonate gap. And what this equates to is the actual anion gap, so this is what the anion gap is for that patient, minus 12, because this is the normal NL normal anion gap. And it's going to be minus the bicarbonate, being 24, this is just a normal bicarbonate, minus the actual bicarbonate. Right? So if we write this out, the delta gap equals the actual anion gap minus 12, which is just a normal anion gap, minus normal bicarbonate, which is 14, subtracted actual bicarbonate. And this is the bicarbonate that you would get off your basic metabolic panel. This is the anion gap that you'd get off your basic metabolic panel. So these two are kind of what is going on in the patient, right? Whereas these two are just kind of the normal values. And that will give you a number. All right. Sometimes that number will be negative, and sometimes it will be positive. And how we interpret that is below. So what we're going to do is we're going to write the equation right here so we can kind of remember it. dg delta gap equals the delta anion gap subtracted by the delta bicarbonate level. And what that equates to is the actual patient's anion gap minus 12, which is just a normal anion gap, minus 24, a normal bicarbonate, subtracted by the patient's bicarbonate. All right? So if the delta gap is less than 1, which means, if it is even negative, what that is telling you is we're just going to highlight this for when we start writing on this. What that is telling you is that there's a concurrent non-anion gap metabolic acidosis in addition to the high anion gap metabolic acidosis, right? Because you only do the delta-delta if it is a high anion gap metabolic acidosis. And why that makes sense is in this equation. We talked about in the last video that a high anion gap metabolic acidosis ahagma, means that there is a extra acidic compound floating around, lactate, keto acids, formic acid. Whereas if you are a non-anion gap metabolic acidosis, that just means you are losing bicarbonate. So if the delta gap is less than 1, what that essentially means is your bicarbonate value is lower than it should be if it were a pure anion gap metabolic acidosis, right? Because the anion gap equals sodium minus chloride plus bicarb. So if it is a pure high, we'll put hagma here just for the sake. Remember, high anion gap metabolic acidosis is equivalent in terminology to an anion gap metabolic acidosis. These are kind of the same thing. They're just displayed differently. So if the delta gap is less than 1, it means that this bicarbonate value is much lower, right? Because you'd say 24 minus 20, and then subtracting that would get you something normal. Is 24 minus 12 is going to give you a higher number here, which is going to make this more negative. And what it's saying is that the anion gap being seen is not representative of what the bicarbonate should be if it was just a high anion gap metabolic acidosis. So you have a non-anion gap component because you're losing more bicarbonate than you should if it was a pure high anion gap metabolic acidosis. All right. If the delta gap is 1 to 2, that is just a pure, simple, high anion gap metabolic acidosis. That is what the delta gap should be if the anion gap is explained by the change in bicarb, which is explained by the high anion gap metabolic acidosis. If the delta gap is greater than 2, it suggests a mixed metabolic alkalosis because the bicarb is higher than it should be if it were just a high anion gap, another lag, a high anion gap metabolic acidosis, a hagma. All right? And that makes sense in this equation, right? If the delta gap is high, it means that this minus this is higher, so this is 24 minus a higher bicarb, making this less, so then the total is going to be higher. That's just simple math. We probably don't need to explain that. But it essentially is suggesting that the bicarbonate is higher than it should be, and the bicarbonate goes up, as we've talked about in a handful of the previous videos, in metabolic alkalosis. Does that make sense? Hopefully spelling it out this way explains why the delta gap is certain ways, and you'll remember it a little better. So it's all about this area of the equation here, and we'll scroll up so you can see it a little better. This area here, it's all about the bicarb level, and if that bicarbonate level is appropriate for just a pure high anion gap metabolic acidosis. Because as we talked about, repetition, you only do the delta gap if you have a high anion gap metabolic acidosis. Otherwise, you do not do it. So if you have a high anion gap metabolic acidosis, you do the delta, and either the bicarbonate value is appropriate, which will give you a delta gap of 1 to 2, and it's just that high anion gap metabolic acidosis, or the bicarbonate is inappropriate. If that bicarbonate is inappropriately low, as we know, that would be suggestive of a concurrent normal anion gap metabolic acidosis in addition to the high anion gap metabolic acidosis, because the bicarbonate is lower than it should be. Your delta gap is too low, so you have this combined disorder. Whereas if the delta gap is too high, right, that suggests that this part of the equation, right, you have too much bicarbonate, you get more bicarbonate in a metabolic alkalosis, and thus you have a combined high anion gap metabolic acidosis plus a metabolic alkalosis. So it's all about this part of the equation and just how the bicarbonate level changes this part of the equation and thus changes the delta gap. Another way to think about this is the delta ratio you'll hear thrown around. So the delta ratio tells you the exact same thing, right? It tells you the exact same thing as the delta gap. It's just displayed in a different way. So instead of doing subtraction, you do division. So the delta ratio is the change in anion gap divided by the change in bicarb. And just like the delta gap, the delta ratio is the measured anion gap minus 12 divided by 24 minus the measured bicarb, right? This is the normal anion gap, this is a normal anion gap, and this is the patient's anion gap. This is the patient's bicarbonate. So if we scroll back up, it's literally the exact same equation as the delta gap, except the delta ratio divides these two things rather than subtracts them. All right? So normal anion gap 12, normal bicarb 24, like we talked about. Change in anion gap, change in bicarb is this, which we talked about, right? We just wrote it out in two different ways. So then they have delta ratio, we have delta ratio meanings depending on what the ratio is. So if the ratio is less than 0.4, it means that there's a non-anion gap metabolic acidosis, all right? Which essentially means you didn't need to do the delta ratio in the first place because you should have already known that it was a non-anion gap metabolic acidosis. So, you know, people put this in here, but we tend to cross it out because you shouldn't be doing the delta ratio if it's a non-anion gap metabolic acidosis to start with, because you would just know that based upon your initial anion gap calculation. Whereas these three are the equivalent to, right, we're scrolling up, are the equivalent to these three. So either you have a combined high anion gap and non-anion gap, you have a just high anion gap, or you have a high anion gap with a metabolic alkalosis. Same thing down here. So if it's 0.4 to 0.8, you have a mixed high anion gap metabolic acidosis plus a non-anion gap metabolic acidosis, which essentially just means that, right, like we talked about, your measured bicarbonate is lower than it should be because you're losing bicarbonate because you have this combined non-anion gap metabolic acidosis. And as we talked about in video 4, our last video, in non-anion gap metabolic acidosis, you lose bicarb, which makes this ratio lowest. If the ratio is 0.8 to 2, it just means it's normal. Your anion gap and bicarb are where they should be for a high anion gap. If the ratio is high, it means you have more bicarb than you should. So you have a combined metabolic alkalosis with your high anion gap metabolic acidosis. So the delta ratio is just another way to think about the delta-delta. So you can have a delta, you can do the delta gap, you can do the delta ratio, whichever one you'd like to do is fine. Both get to the same end point. Hey everybody, and welcome back to another video. Today we're going to be doing a video that is more tailored towards, healthcare trainees or practitioners or professionals rather than the general public, although we always encourage everybody who's curious to, watch the videos and check them out. But we're going to be doing kind of introduction to the arterial blood gas or understanding the ABG. We're going to come out with a series of acid-base videos in terms of understanding acid-base, and this is kind of the start of that. So this will be a quicker video just kind of on the foundational topics on sampling, calculating, what they're good for, what they're used for, all that kind of stuff. So to start this video, understanding the ABG is critical for all nurses, respiratory therapists, advanced practice providers, docs, and more, right? The ABG is a critical component of the evaluation of many different types of patients and can provide lots of great information. What is a blood gas? Well, you're able to do a blood gas on pretty much any place where there is blood. This is typically the veins, venous, the arteries, arterial, or the capillaries, which are between the arteries and the veins. And you can do a sample blood gas, right? You're getting blood and you're checking the gases in that blood on any of these areas. In this video, we're talking about arterial blood gases, but just for kind of further understanding, we drew here kind of an artery in the red going into a capillary in the purple and a vein in the blue. And you can sample, an arterial blood gas from the artery, a capillary gas from the capillary, or a venous gas from the vein. So, this would be arterial blood gas, ABG. capillary blood gas, CBG, or venous blood gas, VBG. And you do these blood gases to look at things like carbon dioxide or CO2, oxygen or O2, and then the acid-base status or pH. And this can give you a lot of information about how well the patient's breathing and how well their kidneys are working and so on and so forth. Just a little intro to how gases work in the blood vessels. This is a red blood cell in the artery carrying oxygenated blood. So you have oxygen on the red blood cell. You also have oxygen floating around in the blood, which is the partial pressure of oxygen, and carbon dioxide floating around in the blood. It goes through the capillary where oxygen goes out into the tissues. Carbon dioxide comes from the tissues into the blood, and then it goes into the vein to be delivered back to the lungs. And there's less oxygen in the red blood cells, less oxygen floating around in the venous blood, and then more carbon dioxide. All right, so sampling. How do we sample? How do we get an ABG? Well, you can actually sample any artery theoretically, but most often the arteries you're sampling are the radial artery, which runs in the wrist, or the femoral artery, which runs in the groin. Far and away, the radial artery is the artery kind of choice. So how do you do it? Well, you start with something called the Allen's test. And the Allen's test is to assess for adequate circulatory flow, collateral flow through the wrist. And what we mean by that is the wrist actually has, and specifically the hand has, two different arterial blood sources. All right, one is the radial artery, which runs kind of towards and along the thumb. All right, and we'll put an R here for radial. The other one is actually the ulnar artery, which runs near the pinky, and we'll put a U here for ulnar. And both of these perfuse the hand with kind of branches of arteries that come out. So the Allen's test is essentially you raise the arm above your head, clench the hand in a fist, and press down. You occlude both of these arteries, so you press down on both of them. The hand should kind of get to be a pale color. You'll then unclench the fist and only release the pressure off the ulnar artery while keeping pressure on the radial artery. And what you want is for the hand to pink up again. And that suggests that you're getting enough blood flow through the ulnar artery to keep the hand well perfused with enough blood. And that means if you were to, injure the radial artery, that the hand would still get enough blood flow. If the hand doesn't pink up, it means that the ulnar artery isn't giving the hand enough blood flow, and then that's very high risk, because if you were to damage the radial artery during the ABG draw, there would not be enough blood flow to the hand, and you could have ischemia or lack of blood flow to that hand. So start with the Allen's test to gauge for collateral flow through the ulnar artery. You'll then palpate the radial pulse in the wrist, right around this region, remember, by the thumb there. All right. Once you have a good radial pulse, and we're not going to go through the details of exactly how to do the poke, we can. Let us know in the comments if you want us to make that video. You poke with a blood gas syringe, which is a certain type of syringe, that artery, and you're always poking in this direction towards the body. All right. You had success. You did a good poke, you got the ABG. You run that blood sample at a blood gas lab. This is separate from the main lab typically, because you use a blood gas machine, and it's rapid results, all right, in 5 to 15 minutes. In fact, sometimes you can do something like a hemoglobin or a blood count, or like stat electrolytes off of blood gas. It's not as accurate as if you were to do kind of the serum electrolytes, but it comes back a lot faster, 5 to 15 minutes in that machine. So it's a stat rapid blood gas test. So once you get it back, what does it tell you and how do you interpret it? So there's a few things that are measured, right, that measures, and there's a few things that are actually derived or calculated from the sample. The pH is measured, and that's the acid-base status of the blood. And the normal values for that are 7.35 to 7.45. We kind of use 7.4 as a general normal. It also measures the PaO2. This is the partial pressure of oxygen in the blood vessel, and that's 75 to 100 millimeters of mercury. So the partial pressure, the PaO2, is how much of this oxygen is floating around in the blood. It's not the oxygen saturation on the red blood cells, it's how much oxygen is floating around in the blood. All right? It also measures the PaCO2, or the partial pressure of carbon dioxide, which is 35 to 45, which we often use 40 as kind of a normal, millimeters of mercury. And again, that is the partial pressure, so it's the amount of free carbon dioxide floating around in the blood. A few things that are calculated. So these are kind of derived from the ABG blood gas. They're not free measurements, meaning there can be some error. The bicarbonate levels are calculated, and that's 22 to 26. We often use kind of 24 as the generic normal. Base excess or deficit, that's how much extra acid or base is in the blood, and that's -4 to +2. And then the SaO2, or the amount of arterial oxygen saturation, that is how much oxygen is actually on the red blood cells themselves, how much oxygen is saturating those red blood cells. All right, and they put the normal in a lot of references as 95 to 100%, although, people with COPD and stuff, kind of greater than 88% can be considered normal. And this should correlate with the oxygen saturation that you see on the actual monitor. All right, so these are all calculated values, whereas these are measured values. So these are the much more important values that we look at because they're directly measured from the blood gas. All right, and the last part of this video is going to be an introduction to calculating acid-base status. So there's a lot to this, and we're actually going to come out with an acid-base series of videos, identifying compensated versus uncompensated, mixed metabolic respiratory combinations of, anion gap metabolic acidosis versus non-anion gap metabolic acidosis, but we're not going to focus on any of these in this. We're just going to do the introductory, kind of simple, identifying an acidosis versus alkalosis, and knowing whether it's primary metabolic or primary respiratory. And to do this, we drew out just kind of a little hierarchy here. So first you look at the pH. All right, if the pH is between 7.35 and 7.45, that is a normal pH. You're not acidemic or alkalemic. All right. If it is not, you can use kind of the generic 7.4. So if it is less than 7.4, you are acidotic. And then you need to look at one other thing, either the PCO2 or the bicarb. And for this, we chose the PCO2. So if your pH is less than 7.40 and your PCO2 is less than 40, that's a primary metabolic acidosis. If your pH is less than 7.4 and your PCO2 is greater than 40, that's a primary respiratory acidosis. Contrarily, if your pH is greater than 7.4, that's an alkalosis. Again, then you look at your PCO2. If your PCO2 is less than 40, that is a respiratory alkalosis. If your PCO2 is more than 40, that's a metabolic alkalosis. So just some examples, let's say our pH is 7.20, our PCO2 is 90, and our bicarb, again, for the sake of this, will be, we'll just say it's 28, all right? We aren't even looking at bicarb right now, but what we look at would be your pH, right? So 7.40, 7.20, it's less than, so it's an acidosis, so A for acidosis. Then we look at our PCO2, it's less than 40 or more than 40? It's more than 40, so it is a respiratory acidosis. All right, this would be like a COPD exacerbation. Contrarily, let's say, your pH is 7.50 and your PCO2 is 70, and your bicarb in this instance will be, I don't choose anything, 19. Again, we're not looking at bicarb to determine these. Your pH is more than 7.4 at 7.50. Your PCO2 is more than 40, so it's a primary metabolic alkalosis, right? So it is an alkalosis, and it is metabolic. All right, does that make sense? We're going to go into this in much, much more detail in future videos, so subscribe and follow along if you're interested. We just wanted to kind of do an introduction to metabolic versus respiratory acidosis versus alkalosis. So for these examples, we used the PCO2 as the second marker we looked at after the pH. But you can replace this with the bicarb if you wanted to. So we essentially have the same little chart over here. And instead of the PCO2 here, we'll write bicarb, HCO3, HCO3. And normal for this, we'll say, is 24, right? So if you are acidotic, your pH is less than 7.40, and your bicarb is low. Bicarb is a base, right? So if your bicarb is low, that means that your acidosis is metabolic because your base is low, right? Whereas your bicarb is high with an acidosis, that means that it is respiratory. So it's the opposite of when we looked at the PCO2. Same thing here, so you're alkalotic. So if your bicarb is high, bicarb's a base, so if your pH is high or basic and you're alkalotic, it's going to be metabolic in origin. And contrarily, if you have an alkalosis and your bicarb is low, that would mean that you are maybe compensating and it's respiratory in origin. All right, respiratory. So the things to think about here, whether you look at bicarb, in this area, or whether you look at PCO2, the things to think about are, what does this bicarb or PCO2 being low or high mean? So bicarb being a base, right? We'll say that's a base. So if the bicarb is low and you have less base and you're acidotic, that's metabolic because your low bicarb is causing that, right? As you can see here. Whereas if your pH is low and you're acidotic, but your bicarb is high, that is conflicting with the pH, right? Because if you have more base, more bicarb, you would expect the pH to be high and basic. So that would mean that what your bicarb is doing is it is compensating for a respiratory acidosis. All right? And we don't want to leave you on a cliffhanger, but we're going to talk a lot about compensation coming up in future videos. So we'll probably leave this there. All right? But I guess here we can do a few more examples. Just these examples over here, but using bicarb rather than PCO2. So just like we did over there, let's say the pH is 7.20, right? That is less than 7.4, so you have an acidosis. And your PCO2, which we're going to ignore in this case, is 70. And your bicarb is, let's call it, actually, let's do this different. The PCO2 is going to be 50. And your bicarb is 14. So if we go down here, pH is 7.40, 7.2 less than acidosis, all right, bicarb of 24, 14 is less than. So this is a metabolic acidosis because the amount of bicarb or the amount of base is low, meaning the low bicarb is causing the acidosis. Whereas if your pH is 7.20, your PCO2 is 70, and your bicarb is, let's call it 30, you still go down the same chart, right? pH 7.40, 7.2 is less than, so it's an acidosis. Your bicarb is 30, so it's more than 24, so it's respiratory because the amount of base is high, but the pH is still low, meaning your bicarb is compensating for primary respiratory acidosis. And again, we'll get into that more. So you can just follow these charts, but you just need to choose one, bicarb or PCO2, and then you just follow acidosis, alkalosis, high, low.
All right. Hey everybody, and welcome back to another video. Today we're going to be talking about venous blood gases. So not arterial blood gases, venous blood gases. And I want to explain what venous blood gases are, how to read them, what they mean, and how they translate to arterial blood gases. So a venous blood gas is a sample that is obviously taken from the venous system, the veins. You can do this in a few different ways. So you can get a peripheral sample. You often see this done from the arm. And this is, more termed a venipuncture, right? Puncturing the vein. You can also do this from a central sample. And this is from like a central venous catheter, a central line. And then you actually can also do a mixed venous sample from a pulmonary artery catheter, which we're not going to go into detail on. Pulmonary artery catheter. So these are the three main ways to sample the venous blood. And why would you want to do a venous blood gas or a VBG, as they're more commonly referred to? Well, honestly, there's two different reasons. The first and primary reason is because we actually can convert the pH, the PCO2, and the bicarb from a VBG
to an ABG. So a VBG can be a surrogate for ABGs in the pH, PCO2, and bicarb. ABGs, right, are harder to get. You got to poke the artery. It can be uncomfortable for patients. It can be harder to actually get the arterial blood. So a VBG is a stand-in for an ABG for these three things: the pH, the PCO2, and the bicarb. The other reason is that actually the SVO2 on a VBG, which we're going to get into, is a marker, a surrogate used for oxygen delivery and consumption, which we'll touch on, although not go into great detail on in this lecture. All right, so what does a venous blood gas actually measure? Let's do blue. So a venous blood gas measures a few different things. All right. It measures the PVO2, and this is the venous oxygen tension. Oxygen tension. All right. What is oxygen tension? Well, the oxygen tension is actually the amount of oxygen dissolved in the bloodstream. So this is the amount of oxygen dissolved floating around in the blood. Not attached to hemoglobin, but the actual dissolved oxygen in the blood. All right. It can also measure the carbon dioxide tension, or the PVCO2, right? And this is going to be the venous CO2 tension. It measures the pH, right, which is the acidity of the blood. Oop, let me mute my computer. It measures the SVO2, which is the oxyhemoglobin saturation. Sorry about that. Oxyhemoglobin saturation. So this is the amount of oxygen actually attached to the hemoglobin, right? Not just the oxygen dissolved in the blood. And then it measures the HCO3, which is the serum bicarb. Bicarb. Oop, there's an R there. Concentration, which I tend to do with brackets for concentration. So with all this in mind, I think a question that, if we haven't directly answered so far, we've indirectly touched on is, why get a venous blood gas? And the reason is twofold. One is it's because venous blood gases can be converted to be reflective of an arterial blood gas, and that arterial blood gas can give you information. So the pH, the acid-base relationship in the blood, a venous blood gas's pH is similar to an arterial blood gas's pH, and we're going to get into how exactly they're different and how to convert them. Same thing with the carbon dioxide levels. If you're worried that someone is retaining carbon dioxide, or you need to verify their carbon dioxide levels for their acid-base status, the venous blood gas carbon dioxide is reflective of the arterial blood gas carbon dioxide. And again, we're going to get into how exactly those translate. The second different reason is that the SVO2, as we mentioned, can be a surrogate marker for oxygen delivery and consumption, which we will just very briefly touch on at the end, and it can be useful for determining shock states and resuscitation for patients in shock. So those are kind of the two separate reasons. One is because venous blood gases, the pH, PCO2, and bicarb, are reflective of an arterial blood gas, and those can tell us things about the acid-base status and whether someone's retaining carbon dioxide or not. And then two is for this oxyhemoglobin saturation in the venous blood, which is a surrogate for O2 delivery and consumption. So what does all this mean, right? For that, I want to kind of draw a picture that is going to be one that, isn't to form here. So this is going to be our stand-in picture for a blood vessel, right? So we have an artery, which goes into an arterial, right, which is a smaller caliber, which goes into a capillary, which goes into a venule, which goes into a vein. And for our purposes within the blood, right, we have blood cells, right, and these blood cells carry our hemoglobin. That doesn't look that great, but that's hemoglobin. And our hemoglobin is going to be saturated with oxygen in the arteries, right? And then floating around in here, we actually have oxygen tension, right? These dissolved O2 molecules. We also have carbon dioxide tension, which will be green, these dissolved CO2 molecules. And all of this is flowing, right, towards the capillary. And the capillary has tissue, right, outside of it. And as these red blood cells go through the capillary, and as this dissolved oxygen and the dissolved carbon dioxide go through, things happen, right? So you get oxygen that flows out from both the hemoglobin as well as the oxygen tension. And then these things keep flowing through. And on the other side, you have your red blood cells, right, that have their hemoglobin that now most likely have less oxygen attached to it because it gave some to the tissue in the capillary. And then you have your O2 tension, right, your venous oxygen tension, which is going to be less than your arterial oxygen tension, and your venous carbon dioxide, which tends to be about the same. So when talking about a VBG or an ABG, you actually structure it in a certain way. So it tends to be, you can write it like this on your paper, write the pH, then the PVCO2, then the PVO2, then the bicarb, then the SVO2. And that's how you can write it. So how do we convert an ABG, right, if we stuck a needle in this area and got a sample, compared to a VBG, or if we stuck a needle in this area and got a sample? It's actually fairly simple, and it's one where a lot of times you don't even need to actively convert them, but there are some kind of data points to keep in mind. So converting a VBG to an ABG. Well, things to note is that your SVO2 can't be converted and your PVO2 can't be converted. So your oxygen tension and your oxyhemoglobin saturation, right? Because going through this capillary, oxygen comes off the hemoglobin and out of the blood. So the oxyhemoglobin saturation and the dissolved oxygen in a vein are much different than they are in an artery. So those two don't equate. But the acidity stays about the same, the carbon dioxide stays about the same, and the amount of bicarb stays about the same. But what is about the same? So for the pH, it's usually 0.03 to 0.04 lower in the venous blood than the arterial blood. All right. For the bicarb, it's usually 2 to 3 milliequivalents higher in the veins than in the arteries. That makes sense, right? Because if your bicarb's higher, your pH that if your bicarb is higher, you would expect your pH to be higher, but it's lower. So that's something to keep in mind, that those two things don't equate. And then your PCO2 is usually 3 to 8 millimeters of mercury higher than your ABG. And this is the one where it makes sense, right? Because if your PCO2 is higher, your pH is often lower. So these are the big differences. With that being said, though, studies have shown that there's significant variability. So some patients it'll line up perfectly, other patients it won't. And because of that, we have to be careful. So if your clinical picture does not fit the venous blood gas you're seeing, get an ABG to verify that they're either similar or not. Right? So verify the similarity. Because if they're similar, then you know that you can go by venous blood gases, and if they're very different, then you know you can't act on that venous blood gas. The other caveat to this, so we'll put a star here, is that in patients that are super hypotensive or have extremes of acid base,
there's been shown to be as much as a 3-time factor increase in variability between VBGs and ABGs. So they're much less, VBGs are much less accurate in terms of comparison to ABGs and those that are hypertensive or with extremes of acid base. Unfortunately, right, these patients, hypotensive patients in shock and extremes of acid base, are often the patients that you need a blood gas on. So just be careful in these patient populations because your VBG might not actually be convertible to your ABG. All right, so usually you can use a VBG for pH, PCO2 in place of an ABG, although you have to understand that there is significant variability, and if it doesn't add up, then get an ABG to verify that your VBG is comparable. In those that are hypotensive and shock or extremes of acid and base, it can be even more variable, so you have to be very careful. And again, it's usually worthwhile maybe getting one ABG and making sure it does does relate to your VBG before acting on the VBG in these types of situations. Okay, I do just want to touch on, and this will be kind of probably primarily another video, but I do just want to touch on SVO2 and what that means, right? So the SVO2, as we talked about, is the oxyhemoglobin saturation. Oxyhemoglobin saturation. So how much oxygen is on hemoglobin. And the SVO2 is part of a VBG that is used, that is not just used to, translate to an ABG. It's a part of the VBG that, you actually need a VBG to get, and not that, for all these other measures, an ABG is always better. But for this, a VBG is actually what you're trying to get. So in the arteries, you have an arterial saturation of oxyhemoglobin that's usually 95 to 100%. So 95 to 100% of hemoglobin is saturated with oxygen in the arterial system. You then lose 20 to 40% of oxygen off your hemoglobin when it goes through the capillary, which leads an oxyhemoglobin saturation in the veins of 60 to 80%. This averages to about losing 25% in the capillaries and having 75% return to the lungs, right? Because that's where the veins are going. And this value, if taken centrally, right, off a central line, because you want to be sampling from that superior vena cava, can be used as a surrogate to measure oxygen delivery and oxygen consumption, which can be useful in terms of managing and diagnosing shock. So let me know if you guys are interested in us doing a video on that. I think it's an interesting topic and one that is worthwhile discussing. But I just wanted to mention that marker, the SVO2 on a VBG, if taken centrally, peripherally you can't use it in this manner, right? Because there's too much variability depending on where you take that sample. It has to be taken centrally off a central line, and that can be used as a surrogate for oxygen delivery, right? How much oxygen comes out here, and then oxygen consumption, or I should say how much oxygen is here, and then oxygen consumption, how much comes out here, meaning how much is left can be a surrogate for that ratio of delivery to consumption.
Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.